Okay. So I'm going to switch gears a little bit and talk about practical tips on, how do you use Acuro to actually augment your skills. We've heard some great research backgrounds. I do want to say I met Will back in probably about 6, 7 years ago, something like that, when you first started developing this device as a graduate student. So I feel, I am collecting an honorarium, but I do feel like this is a really good company. I've seen it for a long time, and I do feel like their interest is really in preventing patient harm and helping us do a better job for our patients as well. And so, some people, when I talk to them about doing ultrasound, I do a lot of ultrasound for my patients. Probably about 85% of my laboring patients get some sort of ultrasound for their neuraxial placement from me. And so a lot of people will sometimes push back and say, well, you know what, I don't want to become dependent on technology. I trust in my skills, and so I'm actually going to try to support that you can get even better in your palpation and your detection skills and your epidural placement skills, even when these kinds of ultrasound devices aren't available. Using them to kind of calibrate yourself and get a better sense of honing your physical exam skills. So I'm going to just review 2 clinical cases very briefly, and I'm going to talk to you about some practical tips on how I sort of structure getting better and making myself better each time I try to do an neuraxial for a patient. And I did receive consent for both of these patients to show their photos. So starting with a case, 35-year-old woman, this is her 3rd baby, she's for an induction, she's otherwise healthy, totally fine, except when we go in and talk to her about her anesthetic, do her anesthetic pre-op, she says, well, you know what, I'm really, really nervous about an epidural. I've had 2 very traumatic placements, and I kind of talked to her a little bit about it. I looked back, one of the notes was at our institution, and it just said multiple attempts, very challenging patient placement, positioning and that kind of stuff. And she herself denied a history of scoliosis. So this is what I got, having her reclining in the bed talking to me. So of course I sat her up, and this is what I saw. And so as you can see, it might be a little subtle, but you can see, sort of there's this little bit of a curve here. So when I started talking about, shoulder heights are a little bit off, or her hip heights are maybe a little bit off. And so I was thinking, this patient probably has scoliosis. I'm thinking it looks pretty obvious to me. But this is after sort of, my using ultrasound multiple times for some of the things I'm going to show next. So basically, the first thing I do is I try to look and see if rib hump is, if one side is more prominent than the other, just to kind of confirm my initial suspicions. And as you can see, this is all built up over here. This is a little bit more flattened, and down below, you see this side is a little bit more prominent. And so these are the kinds of things that I've done since I've started using ultrasound, and I'll explain a little bit in a bit about why I do that. This is another thing that I've developed doing since I've been using a lot of ultrasound. So you see these little, I don't know if people use this, I kind of call it slang sacral triangle. That's a good locator for me. I don't even have to palpate anyone's hips anymore. I look for this, and most patients will have it, and that's a good indicator I've seen using ultrasound. So first-person research using ultrasound, this is usually L5S1 right there. So that's a really helpful thing that I've learned over time to calibrate myself. So I looked at these, and I basically said, well, she probably has some scoliosis. Let me just see how far of a degree of her curve was. And it always surprises me how much rotation somebody can have. So this is me holding, so I was holding this, and a friend was standing behind me just basically taking a picture. So as squared up to the patient as possible, and you can see this huge degree of rotation that this patient had at her L4-5 level. L4-5, L5S1, they were pretty similar. And so as you can see, the Acuro actually gives you a nice line, and it can help you even in this rotational scoliosis. So my technique is always to try to go midline, because I feel like it's less uncomfortable for the patient. You can go perimedian, but you're going through a lot of muscle, and they often complain of a lot of discomfort. And so I tend to like to use this approach. And I found very, very successful. You can just basically go ahead and go in and first pass attempts. I even have my CA1s, attempt this. And again, if they're using this kind of a pre-scan to do this, they have been quite successful. So for her, essentially, I wasn't able to be there when her epidural was placed, but I did share it was actually a colleague of mine who was in the room with me looking at these scans, and she said actually when they went in, they repeated it with the other ultrasound device, and then they were able to place, and she said it mapped out exactly as we had used with the ultrasound, with the Acuro, so that was helpful. Second patient, and I know we're short on time, I'm trying to just go through this really quickly, is a woman who had an induction for labor for IUGR, somebody who really wanted to have a good working epidural because of potential for needing to go back for cesarean delivery. She had unilateral coverage from her epidural that was placed a couple hours ago. And when I looked at the procedure note, it didn't really mention anything about scoliosis, but she was having some need for us to go and replace, so we went in. And so this is what I saw. Again, it sort of looks similar to the last patient, and as you can see down here is where her former epidural was placed. And so essentially what I did, same kind of thing, so this is sort of my exam. You see more prominence over here, not so much down here, so it's kind of like also which way is this curve going to go. So when we looked, again, it's hard to tell in this picture, but we had quite of a similar degree of curve to the last patient in the lumbar spine. And in fact, the needle, this was a first pass attempt by a CA1 resident who was able to quickly get this patient comfortable, and her epidural worked very well from this on. So I feel like this is so I guess my recipe for doing this is I usually take these steps when trying to calibrate myself. So I think level really matters. We heard a lot about that in the Gertie Mark sessions today, how if we're going in, we're often, and from these sessions here too, we're often much higher than we think we are. I feel like after using this, I am more likely to be L4-5, probably about 80% of the time. I'm right at L4-5 when I guess. And another, in those extra times, I'm usually like one level higher. And so instead of being widely off each time. So I look for the sacral triangle, and then I calibrate myself, estimating, and then check it. And then I also look for these subtle signs of scoliosis, which I feel like more and more, I feel like all of my patients are starting to have rotation in their lumbar spines, which is really interesting. Most of the time, I don't usually have to change my angle, but sometimes I'm surprised. And then I basically confirm all of this with ultrasound. So I try to quiz myself up front and then confirm it later. And I feel like this has really helped me be more accurate at sort of guessing that somebody's going to need a little bit more time or a little bit more expertise or the ultrasound to be able to place their epidural. So for that, I would say, don't forget to stop at the booth 16, to start scanning yourself. And I think we're going to go ahead and take some questions now.
Thank you for the presentation. I am a CRNA that I work in Kentucky. My name is Cheryl Parker, and we have an exclusive OB anesthesia service. And if anybody in here knows anything about Kentucky, we have a very large BMI population of patients, and I want to thank Will and the makers of this device because we have seen incredible success rates with first-time pass, in a training environment with BMIs as high as 73. So it's been a wonderful device for both for teaching and patient satisfaction. Thank you.
Thank you for your comment.
Yeah. Hi, Josh Younger from Henry Ford in Detroit. Quick question. I mean, we had actually the luxury on our labor and delivery to actually have an ultrasound present at full time. Do you find that there's an advantage to this device over traditional ultrasound? And if so, what is that besides its compactability?
The major one is it's so easy. So we've got it, you saw our big ultrasound, the console, and you're clanking it in, and we can't stand bringing it into the room, and it's a big barrier to use. This you just pick up and you walk in, have in your pocket, and just take it out if you need it. So that is a huge factor that we found influences use.
Yeah, I was going to say, for us too, the 3D mapping image below helps you, like I said, I use it for a lot of, midline rotation, rotational correction. And so I think it does help residents learn the anatomy a little bit better in scoliosis and be able to anticipate in the future. And that's an advantage over the regular ultrasound.